Hello everyone, I'm Anas Al Ubaidi, and the topic or the title for the session is Substance Use Disorders Documentation Challenges. Within the chapter that is within the title of Review of Psychiatry Scribing within the Certified Medical Administrative Assistant course program by ACMSO. Introduction. Substance use disorders, for short SUDS, are among the most pervasive and challenging conditions in healthcare impacting individuals from all socioeconomic backgrounds. These disorders, which encompass the misuse of alcohol, prescription medications, and illicit drugs, carry immense social, psychological, and medical consequences. They are often intertwined with co-occurring mental health disorders, chronic illnesses, and socioeconomic hardships, making their assessment and treatment highly complex. Documenting SUDS accurately is a critical responsibility for advanced medical scribes, as these records guide treatment, enable continuity of care, and meet legal and insurance requirements. SUD documentation is distinct and highly nuanced compared to general medical scribing. It requires careful attention to the patient's substance history, patterns of use, withdrawal symptoms, comorbidities, and treatment progress. However, accurate documentation presents unique challenges, including the stigma surrounding substance use, patient reluctance to share details, and the sensitive nature of these records. For example, a scribe must precisely document subjective statements while avoiding language that casts judgment, such as patient admits to using illegal substances versus patient reports a history of methamphetamine use over the past year. Additionally, these records must adhere to strict confidentiality rules, such as those outlined in 42 CFR Part 2 and CFR here Code for Federal Regulation, which go beyond HIPAA protections. The documentation must also capture risk assessments such as signs of overdose, withdrawal, or suicidal ideation linked to substance use, requiring scribes to be vigilant about red flags that demand immediate attention. For instance, noting patient reports taking 40 milligrams of oxycodone daily, attempted self-detox with significant nausea and vomiting for 3 days, is critical for identifying withdrawal risks and creating an appropriate treatment plan. Key points: capturing a comprehensive substance use history, types and duration of substance use. Example here, patient reports daily consumption of 1 bottle of wine for the past 3 years. Patterns of use. Example, patient states cocaine is only used socially 2 to 3 times a month, but acknowledges increased frequency during stress. Triggers and environmental influences. Example, reports heavy use of cannabis following arguments with partner. Previous treatment attempts. Here, not any detox programs, inpatient or outpatient rehabilitation stays, and medications prescribed previously, for example, methadone or buprenorphine. Specify outcomes like relapses or improvements. And here is a diagram showing the comprehensive substance use history. Documenting withdrawal and overdose risks, withdrawal symptoms and severity. Capture physical and psychological withdrawal symptoms. For example, patient reports shaking, sweating, and mood instability during attempts to stop alcohol use. Use standardized assessment tools like the Clinical Institute Withdrawal Assessment, CWA or CIWA, when noted by providers. Overdose history include details of past overdoses, naloxone interventions, and emergency history. Example, patient overdosed on heroin 6 months ago, revived with naloxone by paramedics. Recognizing critical signs. fatigue, confusion, respiratory depression, or extreme agitation may be signs of acute overdose or escalation. For example, documentation. Example documentation here: patient presented lethargic, pinpoint pupils noted, opioid-induced history, opioid-induced respiratory suppression suspected. And here is a diagram on withdrawal and overdose assessment. Co-occurring conditions in mental health. Documentation. Psychiatric comorbidities record overlapping diagnoses like depression, anxiety, PTSD, post-traumatic stress disorder, or bipolar disorder, particularly as they relate to substance use triggers or progression. Example, patient reports increasing methamphetamine use correlating with heightened anxiety episodes. Chronic illness management. Document conditions exacerbated by or contributing to SUDS, such as hepatitis C, liver cirrhosis, or cardiovascular disease. Example, LFTS liver function test significantly elevated. Patient notes excessive alcohol intake contributing to hepatic dysfunction. And here is a diagram on understanding co-occurring conditions in mental health. Confidentiality and legal compliance. 42 CFR Part 2 regulations. CFR here Code for Federal Regulations. Understand additional confidentiality regulations covering SUD treatment documents beyond HIPAA. Require explicit patient consent for sharing records with external providers. Documentation example, patient signed authorization allowing coordinated care with counseling services and primary care physician. Patient-centered language, avoid stigmatizing or judgmental language. Replace phrases like patient admitted guilt over drug use with patient expressed concern about dependence and expressed motivation to change. Ethical considerations when addressing minors or legal cases. Ensure clarity and neutrality in documentation with objective assertions. Standardized assessment tools, screening and evaluation instruments incorporate tools like gauge questionnaire (CAG) to assess alcohol misuse. Example, positive result on 2 out of 4 gauge criteria indicating likely alcohol dependence. DAST-10 DAST-10 drug abuse screening test quantifies drug abuse intensity. SBIRT screening brief intervention referral to treatment framework guiding patient-provider conversations and documentation strategies. Ongoing monitoring. Integrate progress tracking by documenting scores on these tools over time. Documenting risk and treatment plans. Harm reduction techniques include prescribed treatments like naloxone kits, ways to decrease harm, or safe use recommendations. Example, patient educated on safe needle use practices referred to syringe exchange program. Medication-assisted treatments match MATS. Document medications like Suboxone, Methadone, or Naltrexone. Capture compliance and reported effectiveness. Example, documentation currently on buprenorphine 8 mg daily reports reduced cravings. Behavioral interventions, not therapy models used, such as CBT, cognitive behavioral therapy for relapse prevention, or peer support meetings like Alcoholics Anonymous thoroughly. Summary tables. Here we have table on comprehensive substance use history documentation, table on withdrawal and overdose symptoms, table on co-occurring conditions and factors, table on comprehensive confidentiality standards, table on treatment plans and monitoring, and next we will revise what we have covered via this lecture through some MCQs or multiple choice questions. Question 1. Which of the following is the most important detail to include when documenting a patient's substance use history? A. Frequency, quantity, and method of use. B. The patient's career background. C. Names of family members aware of the substance use. Or D. The patient's reaction to previous legal consequences. It is A. The answer is A. As accurate documentation of the type, frequency, quantity, and method of use is essential to assess the severity of the substance use and guide appropriate intervention strategies. Question 2. What is the primary purpose of adhering to 42 CFR Part 2 in substance use disorder documentation? A. To ensure the records are stored digitally. B. To protect patient confidentiality for substance use treatment records. C. To simplify insurance reimbursement. Or D. To allow healthcare providers unrestricted access to patient records. It is B. To protect patient confidentiality. As explanation here, 42 CFR Part 2 adds a layer of protection beyond HIPAA for substance use treatment records. Question 3. Which standardized tool would best be used to assess the severity of alcohol dependency? A. Gauge questionnaire. B. GAD-7 scale. C. PHQ-9 score. Or D. MMSE test. It is A. As the gauge questionnaire is a commonly used tool to screen for alcohol dependency and evaluate the severity of misuse. Question 4. What key factor must be documented when a patient is receiving medication-assisted treatment, MAT, for opioid dependency? A. The total duration of the past sobriety. B. The number of counseling sessions they've attended. C. The prescribed medication name, dose, and adherence. Or D. The patient's family history of substance use. Definitely C. As when documenting MAT, it is crucial to include specifics about the medication prescribed, for example, Suboxone Methadone, its dosage, and the patient's compliance with the regimen. Question 5. Which of the following is a significant red flag to document for a patient at high risk of overdose? A. Patient reports occasional alcohol use at social events. B. History of being revived by naloxone following heroin use. C. Use of prescribed non-steroidal anti-inflammatory drugs, NSAIDs. Or D. Past use of over-the-counter benzodiazepines abroad. It is B. As a history of being revived by naloxone indicates a prior opioid overdose, signaling a critical red flag. This history must be carefully documented to ensure proactive measures are taken to mitigate risks, such as providing harm reduction strategies or intensifying treatment. And here we come to the end of this lecture. Thank you very much and goodbye.